like to call Dr. Sunil Khetarpal sir, who is the Director HPIE, New Delhi. He is a moderator of this panel discussion. Can we have you over here, sir? Come on everyone, can we make a louder applause for him? And now the stage is yours, sir. You have to choose the esteemed panelist.
So much. And I have with me a very esteemed panelist. I would like to invite Mr. Rajiv Nath. Of course, Mr. Rajiv Nath, he needs no introduction. Mr. Rajiv Nath. Mr. Rajiv Nath, please. He is the Managing Director, Hindustan Syringes and Medical Devices, and Forum Coordinator of the Association of Indian Medical Device Industry, that is called Ahmed, Faridabad. Then we have Professor Dr. Rajesh Shah. I think he also needs no introduction, everybody knows him, consultant surgeon with medical legal expertise, but he always uses his punchline. Even on his visiting card you will see Dawa or Dawa Bina Ki Duniya. Dawa or Dawa Bina Ki Duniya. So this is Dr. Rajesh Shah. Now we have another panelist, very esteemed panelist, Dr. K.B. Sood, Managing Director at his Nose Consultants Private Limited. Dr. K.B. Sood, sir, please. Then we have Dr. Ahmed Meckclai. Dr. Ahmed Meckclai, the founder and CEO, AAA Healthcare Consultancy Services, Mumbai. Dr. Ahmed. Dr. Ahmed, please. Then we have Mr. Rajan Verma, who is the Director and Business Head, MDD Medical Systems India Private Limited, based out of Gurugram. See, the Government of India, Ministry of Health and Family Welfare, the Medical Education Division, laid down guidelines for establishment of new medical colleges which are attached with existing district or referral schemes. This was a centrally sponsored scheme, and during the 11 5-year plans, healthcare facilities in India have been upgraded substantially. And the healthcare facilities, especially in private sector, have grown exponentially in the country. Now, India has the highest number of medical colleges in the world. We have about 650 medical colleges in the world. We produce nearly 60,000 medical graduates, MBBS doctors, and 25,000 postgraduates in the country. They are specialists in the country every year. Now, medical colleges, the basic issue, the challenge or the problem is the medical colleges are spread unevenly, and we all know that the urban-rural disparity, and also the medical colleges, the private medical education in the private colleges, they are not affordable for the poor people. So this also necessitates increase in MBBS seats in government medical college. Most importantly, this has been, I think, discussed since morning. Even Dr. Rai was also mentioning about the human resource. There is always a shortfall of human resource in healthcare across the country, and hence the government is implementing a centrally sponsored scheme for establishment of new medical colleges by upgrading the district or the referral hospitals, preferably in under-deserved districts of the country. So the medical colleges would be established at an estimated cost of rupees 189 crore per medical college, and there will be a sharing of fund between the center and the state of say 75% to 25%. 75% is the central share and 25% is the state share, except the northeast and some special category states like Himachal, Jammu Kashmir, and there it is 90:10. The state share is 10%. So now with this background, now we are coming to this topic. Should one district, one medical college be supplemented by one healthcare city to mitigate skewed manpower and per capita bed ratio? My first question will be to Mr. Rajiv Nath. Mr. Rajiv Nath, I think, the very goal of the clustering, what we are here to discuss today, is the clustering methodology is to be objective, replicable and sustainable. So do you believe that Indian healthcare is currently at a stage where these objectives can be met?
In that respect, yes, I would say India is definitely in a progressive state where many of the objectives can be met, but the disparity definitely is huge, and the way forward needs to be restructured. We've got 766 districts in the country. To have one medical college in each of these districts, when you already have 650 odd medical colleges you mentioned just now, is going to be a huge challenge. And is it really required? We have to be realistic. We've been talking about health for all since year 2000. Now it's 2022. Where are we against that target? So I think targets need not just be statements which are not going to be achieved just as a wish list. Targets are there which are achievable, which we can achieve and get the confidence, and then put higher targets for ourselves in the next coming forward over there. So regarding the cluster approach, we definitely do have some success stories. We do need to take it forward over there.
Okay, great. So what you mean to say is that we, in fact, we have to look for a sustainable project, and though it can be achievable, as you mentioned, that we do have some examples of such a cluster hospitals, but then it's going to be a great challenge for the country, and it's so for, see, if I may add something, it is not only the infrastructure we are talking of. Because when we talk of a medical college, it is not only the building and the equipments, where the people, where the specialists, where the doctors, where the nurses, where the paramedics.
There are so many hospitals lying empty, even right now.
Even absolutely, in the government hospitals, you see many of the aims, which we have now in our country. Infrastructure is there, building is there, very nice to look at. Everything, equipments are there. Where the people, where the specialists.
You mentioned 180 crore rupees just now in introductory remarks.
Yeah, 189 crore for each hospital they are going to spend.
Money is, I would say, always in today's date secondary. The most valuable asset is the human people. And after that, again, always is the implementation part. So that's, I think, where the biggest gap is.
Absolutely. I think I must also say something here. The district hospitals which we have in our country, as he mentioned, 766, even they are sharing their specialists across the districts. ये नहीं कि एक district में आपको सारे specialists मिल जाएंगे, दूसरे में दूसरे district hospital में मिल जाएंगे. So this the specialists and the doctors are specialists. They are shared among the district hospitals. आप सोचिए then where are you going to have dedicated specialists for each district hospital? Thank you. And now I would like to put up a question to Dr. K.P. Sood. Dr. K.P. Sood, sir, what are the three key issues or challenges facing our healthcare system today? And how do you think this healthcare cluster city, which we just discussed, can help solve these issues? What are the issues which are facing healthcare?
See, I have been in this line for almost 40 years. I have made medical colleges and other things also. My problem is that doing a civil work is easy, but running the hospital, not only in terms of doctors, but also in terms of nurses, technicians, paramedicals, is not possible because they are not just available. And earlier what used to happen was that because of MCA regulation, we used to shift the whole lot of manpower from college A to college B to college C. Even that has been controlled, but where are the people to teach? I have made All India Institute of Medical Sciences in Bilaspur. It has been commissioned thrice. But every time, staff is not there. Now, students are there, where they are going? From Srinagar, they used to, from Rishikesh, they used to come to Delhi to study. Delhi itself is overstaffed, 900 PG students. How can you take another 300 students or 400 students? So that is the problem. It should be a comprehensive policy that you develop the teachers, you develop the teaching capacity, and then open the
With proper planning, you mean to say?
Proper
Absolutely,
planning.
yes.
Otherwise,
And-
it will not lead to anything. Second thing is that we don't have standardization. See, I'll tell you, compressed air is a drug in whole of the world. In India, it is not a drug. You talk to drug controller of India, he says it is not in my hand. You have to make a pharmacopoeia commission, you have to do this thing. Then it is a 3 to 5 years process. Now, before you kind of implement MGPS fully, do that process. Halfway, how can you do that? Third thing is that we don't have a policy for controlling the delivery of healthcare. Today, the role of GP has gone down. Now everybody thinks I got a headache, I should see a neurosurgeon, I got chest pain, I should see a cardiac surgeon. This will not work. You need a system. England has got a system of NHS where you first go to GP. In America, you have a system where, because of the cost, you go to the GP. So some system has to be there so that it is regulated, and everybody does his specialized work where it is required. So these are three major problems that Indian healthcare.
Yeah, sure. If Dr. Rajesh would like to add something, the major challenges, anything else you would like to add?
I had an experience of inspecting the various medical colleges before they are given the status of the medical college. The problem I had observed, I would not name any college, but I had observed, in few of the colleges we found out that the morning before we inspect the college, the buses were full of some workers were brought to the college and they were asked to get on the bag, and whenever their names and figures were shown to us that they are admitted patients, Medical Council, when they created the certain norms, but fulfilling the same norms, I think it's a big challenge, big problem. And even present 650 colleges, when we are not providing the proper infrastructure, proper services, requirements, increasing the numbers is not going to survive. It is just as good as the promise of the 15 lakhs rupees. We are still waiting for in our account. So same thing is going to create a problem.
On a lighter note, then absolutely very valid point, Dr. Shah. And I would like to put another question to you, Dr. Shah. As a country, we recently, the world has attained the population of 8 billion, I'm right, yes, 8 billion. And our share, the Indian share, India's contribution is 1.3 billion. That is 18% of the world population lives in India. Now, as a country that is home to nearly 18% of the world's population, India faces a massive challenge in building its healthcare infrastructure and has to take long strides in reducing the dichotomy of curative versus preventive and urban versus rural. So, in the delivery of healthcare services, what could be the next step for this, if you may throw some light on that?
Practically, whatever infrastructure till we have created, first priority should be given to maintain its proper entity. That is the first priority, because whatever is available to us, we are not providing things. One of the medical college on the hills I had visited, they right from me, I was a fourth visitor, because they were attempting, it was a government medical college, they were attempting every time, and every time some benefits were given to them to provide this structure. But ultimately what I have observed, there were so many staffs, specifically one radiology department was totally vacant, 0 faculties. In such a medical college, if a 0 faculty of radiology, how that college can work? You have rightly mentioned it is 18%. Yes. Total population of the world. But the real scenario, what we are facing, what is the GDP is provided for medical and health services. It is very, very meager amount that has been given, and without the blood, we cannot survive. Same thing without the economics, colleges comes. Creating the number of colleges is not going to solve. And change in the mentality of this providing the services. What we are at present facing, the 20% population in the urban area are provided with the 80% of the facilities, and 80% of the rural population is provided with the 20% of the facilities. So still we cannot change this scenario. It is next to impossible to provide expected or dreamed.
All right. Dr. Ahmed, I think I would ask you the same question. I mean, coming back to the same question for you, and if you can say something on the curative versus preventive and the urban versus rural, as he already mentioned that 20-80, 80-20, you know, if you can add something.
The stalwarts have already answered the question. I think there's a dichotomy. I think one of the few consultants in this country mapped 18 states in India only for oncology care for the Tata Group. And it's sad that people have to travel sometimes for a minimum of 6 hours to 8 hours to a day and a half just to reach proper care. Now, while we're talking about this and setting up medical colleges, everyone knows that human resource is going to be a huge challenge. But our rules and regulations, if you want to get affiliated with the IMC or the NMC earlier, you have to have a certain number of professors, assistant professors. Where is all that manpower come from? Secondly, the training of nursing and paramedics. And this is also a combination of one, training, and second, economies. The same nurse who earns 10 in India today earns 25 in the UK and is also highly respected. Are we doing that? No. So we are going to have this problem until there is a top-down approach where the healthcare system as a whole is given its right place and importance. And I only hope that the pandemic has woken the people in the positions of power to understand that if there's no health, there's going to be no wealth.
Right. As you were mentioning about the pandemic,
I'd like to add one thing.
Yeah, sure, please.
See, in Delhi, we are sitting in Delhi. One executive engineer, electrical, looks after 28 hospitals. Do you think it is practically possible, physically possible? So that is why in the government setup, that is the state of affairs in your hospital. So not only that medical manpower, but also your maintenance, engineering, everything has to be backed up, has to come to that standard where they start looking after healthcare and its specialties.
Right. Yes.
Private colleges are also running in such a way, because ultimately the goal of the private colleges is to earn, is not to provide the services. And in that situation, what is happening? The staff availability, many are on the road just for the road, because they have to show that certain faculties are
Ghost faculty, you call it. Yeah. Only on the paper, yeah.
So that is the scenario what we are facing at present. Same thing, even in Parliament, the answer was given in 2018 that we are above the WHO human requirement of governments. And what you mentioned is a correct thing. We are far behind still. But what is in that answer? They have considered the Ayush doctors also with the allopathic doctors, and they have shown that the figure is much higher than what the WHO never recommends Ayush system to be considered. We answer in such a way that we are on a higher side. What is the recommendation of WHO?
Absolutely.
This is the scenario we are facing.
Very true. And we were talking of the pandemic. I know, pandemic, I think everyone, we have gone through this pandemic, and this was a very unprecedented situation which we all have faced during our lifetime. Maybe some more senior people must have faced the previous pandemic also, but we don't wish to face another pandemic in our lifetime. So pandemic was like, it drained away all the resources, and it has had a great impact on practically all the sectors in the industry, name any sector. So now my question is to Mr. Rajesh Verma, Mr. Rajesh Verma. What are your views on, as the world looks to rebuild and recover from the COVID-19 and 19 pandemic, healthcare and its underpinning services have and will take center stage in future. of course, because healthcare was the center of attraction during the COVID. And now, once we are recovering from COVID, I must say we have almost recovered. Now, these services will take center stage in the future narratives of economic growth across the globe. So, can you just throw some light on this?
Sir, thank you for your such a wonderful question. And my first reply to your first point is that, is our system safe to use? Are we building up the healthcare which is safe to use?
Safety is most important, of course, yes.
A country which we are saying 1.3 billion people. Are we having one country, one standard? We're talking about we're building up so much healthcare, we're building up every district, one hospital. Consultants are there, architects are there, government of India is doing. Are we building up a system which is going to run for years? Is our system safe to use? Because all the medical services are dependent on the infrastructure part. You can build up a very good hospital. Doctors are very good in India. Somebody told today that we have the best doctors in the world. Do we have the best infrastructure? Do our system works? Is our system safe to use? Is the contractor working there have a safe contractor license? Do we follow permit to work norms? Until we will not improve that thing, the country is not going to change. I am talking this thing on behalf of the industry part. Because we as a company look after the major part of the healthcare infrastructure, which is the backbone of a system. And for us, we always say one thing. System should be safe to use. System should be safe to save lives. Are we saving the lives? During the COVID time, it was not that oxygen was failing. It was our system failure, design failure was there. The people who are doing the designing on behalf of government, Dr. Sood sir is very experienced. He's like 28 hospital well electrical engineer is handling. Did that engineer know what is medical services? The consultant, the architects who are working, do they have the license to do all these things? Just because people are very good, very intelligent, Indians are very good. But when we go outside, I'm very fortunate to understand this thing. Why we are still called as a third world country? Why can't we be first world country? Why our people are not given importance outside India? This is a major challenge. If you have to rebuild our system, we have to rework on this thing. Let us have one standard for one country. India should follow one standard and India should follow safe to use standard. If this we can do it, we can save lives. We can rebuild our system better than what was there. On other things we are working that we will do this, we will do that. Prime Minister saying make in India. Are we building up really make in India? Are we building up a system for the country? Today only what we are saying is that pandemic has happened. This is a major problem. Oxygen was there, ICU bed was not there. Are we rebuilding up? Because now pandemic is over, people will think that oh, it's okay, next time it will not come. You are right. Maybe we will not be fortunate to see.
We have become complacent actually. Complacent. Yeah.
I would just like to mention a simple word of gratitude to MDD medical systems, especially Rajan. Because in COVID I was forefronting to Maharashtra and built almost about 10,000 beds and 2,000 ICU beds in field hospitals. And the first thing that Rajan came and when I contacted him, he said, sir, I'm not compromising on safety, I'm building it for larger capacity. I said, but they don't have the money. He said, sir, you decide, you're the consultant. I said, Rajan, you're the expert, you do it. He did it, and I promise you, my 200-bed ICUs could take up to 300 patients. So you see the multiplying effect. And none of them had a problem with oxygen. It was only because the infra was designed to take an extra load, which no one anticipated. So I think that's...
Actually what I would like to add here is that when we are talking of safety, it is not only the human behavior, like your washing hands and following all the infection control practices by the staff, but the building engineering control part, the building design, whether we are safe. If I am working in a hospital, if I am working in OT, whether I am safe, the patient is safe. Not only the human behavior that you have washed hands, you have put on the PPEs, but of course the design, whether the modular OT, whether your HEPA filters are working properly, whether the validation of HEPA filters is done periodically, whether the HEPA filters is changed, the laminar flow is working properly. So all those the design, I think, is very important, because no patient goes to the hospital to acquire or to get the infection. He goes there to become all right and goes back home
So,
safe.
sir, going back to his question,
Yeah.
who's designing it? Are experts designing it? No. It's an architect who may have never done a hospital is designing a hospital. Or it's a contractor who's making a hospital who doesn't have the ABC knowledge or the H of the hospital understanding.
Yeah,
Exactly, that's what's happening.
See, hospitals which are built long ago, so I mean, difficult to, it's all mindset whether they want to change, and they want to have this what you are saying, that the most modern or modular OT. But the new hospitals which are coming up, or if we can really advise them, and if they are aware of this problem, that the patient safety is so important, that from the design or from the planning itself stage, you involve the architects and all the experts, I mean to say, so that ultimately we provide safe care to the patient. That is our aim actually. We want to provide quality and safe care to our patients, and all of us who are working in the hospital should also be safe. Right. Yes, sir.
I want to tell you that medical technology changes every 4 years. So what you have to do is make the hospitals which can adopt the new technologies, as well as train your staff.
Change.
All your nurses,
Absolutely.
other people, they have to learn. So putting a clinical training nurse in a hospital, you can teach is required. Nurses available. All good nurses go abroad.
Yeah, I think very valid point which Dr. Sood has raised. Now I'll come back to Mr. Rajiv Nath. Mr. Rajiv, we are talking of now the spent on healthcare. India spends the least on its healthcare and has the lowest number of beds. That is 0.5 bed per 1,000 population. This means that only half a bed is available for 1,000 people in public hospital in India. So do you think this initiative by the government, which we discussed, it will pave the way for better healthcare infrastructure in India?
I think we just use the word ghost. So we are seeing the current status over here, and it's not the problem of the government. I would say it's a problem of the Indian mindset of the investors and the entrepreneurs also. When somebody succeeds in a mall, there'll be 10 malls around it, and after 3 years, you'll find they become ghost malls. Somebody succeeds in making one medical device, there'll be 20 people running to make the same medical device and to repeat a success story. So we put too much water and we kill the plant. Now we are chasing medical colleges and we're making ghost medical colleges. So quality is important, chasing numbers is not important. Whatever little bit is there, even if it's a GP, if he's a good GP, he'll have a queue of patients outside. Whether he's charging 10 rupees or 100 rupees, doesn't make a difference. So it's always quality that is important. I would say not quantity. Quality will bring quantity.
Absolutely, yes.
Not other way around. Quantity will never bring quality. And coming back to the topic over here about this issue about beds, the biggest shocker for me was because during the pandemic time, as Ahmed, I was reaching out to the hospital bed manufacturers and asking them, why aren't you able to make ICU beds? You are making the basic engineering beds. Now to convert an engineering bed, basic mechanical bed, into an ICU bed, what's the big deal? Why are we importing beds from Stryker? Why are we importing beds from Milleron? I don't make beds, but it didn't make any sense to me. We use high technology machinery in the factory, and we make our own machinery also, but it didn't make any sense to me. You just need some motorized components in the bed. You just need to add on some electronics over there. And we cannot even make what we call as smart beds in the country. So, definitely I think what's been mentioned over here is very important. A holistic view is important at the national level. We created in 2018 or 17 the NHP, National Health Policy. If that policy in its last paragraph and its last chapter says very clearly a policy is only as good as its implementation. A monitoring mechanism has to be created. Now, if you create a policy and just file it, and later on you go and visit a joint secretary and ask for follow-up on any of that policy issues, and he just smiles and laughs it off, how will the country progress? Many wise people had spent days and months and hours in creating a policy framework. So, once something has been created, a plan has been created, it has to be followed. There has to be a monitoring exercise. Otherwise, it becomes a frustration for people like us who mean well and want to contribute, but when they find that the taxpayers' money is being wasted, resources are being wasted, or the resources are not being equitably spread around.
Yeah, you like to add?
Yeah, so I don't think that we are discussing this here. The government has its own set of panel discussions happening, and these two will never meet. Because they will do their panel discussion, we will take out our frustration here about change, and eventually they will decide what they want to do. So unless we create a mechanism where the decision makers sit across the table with experts and formulate a safe change healthcare package for the country, we are not going to go anywhere.
Majorly, the healthcare is provided by the private players, and it's a public-private partnership. Government alone cannot reach out to people. I mean, you know how much share the government has in the provision of healthcare in our country, and it is very important for the government whenever they frame any policy to involve the stakeholders. I mean, the private players also. It should not be a one-sided policy.
And even the private players should not be selective few who are holding the
of
line.
course.
Because the 4 or 5 players go there, they take things
Actually,
to their
this is what
advantage.
is happening.
They take it to their advantage.
That's important, yes. And the policy is framed, but the major problem with the policy is that, the implementation part. And after that, very rightly said by Mr. Rajiv, the monitoring part. So, policy frame, implementation, monitoring. So, everything has to be in place. It has to be in letter and spirit. So, my next question would be to Dr. Rajesh Shah. Another major issue is that India has the lowest number of doctors. So that we have been talking about 0.9 per thousand population compared to other major economies where the doctor to population ratio ranges between 2 to 4 per thousand. We are almost nearly 1 per thousand. So there are 2 doctors to 4 doctors per thousand population. So how do you think private sector can contribute in the strategic imperative in this?
The same thing is the medical education problem. Government should come forward to take up the responsibility of the health and education. These are the 2 most important parameters of the society, and that should be majority to be funded by the government. But unfortunately, on the name of public-private partnership, so many games are going on, and in that situation, the health and education both are present solely. If you see the majority of the corporate hospitals, how many medical professionals are involved in the building and managing these hospitals. But in that circumstances, the result is in our face. We are seeing what is happening. So certain changes are needed, and government should come forward to provide a better GDP from the different things, specifically in the health and education. When it is being done, then and then only we can have some way of it. Otherwise, what is going on is going to be more rather than better and better, not worse and worse.
All right. Yeah, sure.
I must compliment one thing about the public healthcare system. In the pandemic, it has been completely been shown and proven that it's the public health which was more resilient, more empathetic, more inclusive for the patients than even private healthcare. And we must applaud that. So even with the most meager resources, the brave doctors were the ones actually who used those resources very bravely and equitably and came forward about there. And that's again shown the importance of public health care. But when we see the latest reports from Niti Aayog, that's the strategic think tank of India, we find that they are encouraging more and more public health care to become private, which will take out the excess of affordability of many people who can't already afford private. They are the ones who need the public ones. And we are reducing the public ones and getting a bigger imbalance over there. So you already have 80-20, it might become 90-10. And that's a big worry, I would say, for us to consider over there. Of course, we are private players and we supply to both private and public. But I think what's important, especially the primary healthcare, district level, public healthcare has got such a strong role to play. It can never be taken over by private. And if to do that forcibly, to convert a PHC into a private healthcare center, will make it out of access for most people in that village or township.
I agree with Mr. Rajiv though, because the government has done a commendable job during pandemic, even post-pandemic. You see, Ayushman Bharat, it is now 4 years old, and Ayushman Bharat digital mission is 1 year old, I think. The digitalization, the Ayushman Bharat ABDM is a wonderful digitalization in healthcare. If you see, it's a great example. And Ayushman Bharat is, it is the biggest health insurance, the largest health insurance in the world. Okay, we all know about Ayushman Bharat. So I think we must commend the work done by the government. It is, and they are actually, a lot of post-pandemic, you see, people are more aware of the health insurance, digitalization, medical tourism. So all these things have now picked up post-pandemic. The post-pandemic era is a great opportunity actually for all the sectors in the healthcare industry. Dr. Sood, sorry, if you would like to add something.
I want to add to this a living example. See, when USA shifted to private healthcare, almost 40% of their population could not afford healthcare. Till Barack Obama came and did changes, today also about 5 to 8% population is there and the visitors are there who cannot afford. But it has come down. Otherwise, the moment you start shifting to private, the ratio of people who actually have that now and the ratio who will have that after the private healthcare becomes the principal healthcare provider will fall. It is there for you to see.
Right. I think we'll now have another last question probably to Dr. Ahmed and one more question to Dr. Sood, then we'll wind up because we are now on time. Dr. Ahmed, this is on something on GDP. On average, India spent only 1.3% of its total GDP on public healthcare between 2014 to 2019. And even after including the out-of-pocket expense, the total expenditure was 3.5% in 2018, which still stands at the lowest and as compared to other major economies. So apart from one district, one medical college, what else the government should do?
I think, as I've stated earlier as well, I am totally a con against this one district, one medical hospital. But I think the other good measures that the government can do is strengthen their public healthcare system. You've got fantastic PHCs lying in the remotest of villages with either a wall broken or no toilet, no shower, no connectivity. How will a doctor function even if he wants to function? You focus on strengthening that rather than thinking of building a 200 crore building. I've done umpteen number of studies for corporates who want to enhance or support the government to uplift the rural sector. They are ready to spend the money, but when we've done the study and gone back, Akka Sahib Naya Mantarya, the guy is ready to pump in 5 crores to uplift a PHC, take the money and move ahead. That is the mindset change that needs to be created. And by strengthening the rural side, please also understand you're stopping the flow coming to the major cities. Today, even for a common cold, they're coming. So why? There is a structure, just strengthen it. Look at that more seriously rather than setting up a 200 crore hospital. I think that step if we start taking, I think we will have a very strong networking system, which will definitely change the landscape of healthcare for the common man.
Thank you.
I want to add to this. Basically, your health policy should take charge of the health of Indians. See, Mohalla clinic was one of that direction, but because the people who are involved in that did not understand what is health. So they, instead of putting a nurse practitioner, which is must very cost effective, they have put a doctor. The moment you put doctor in a Mohalla clinic, the purpose is defeated. You have to take charge that I am responsible, I will take care, and then you will find suddenly the number of visits and everything will reduce, because today everybody is going to a specialist because they consider GP is nothing. So that is one thing which as a policy you have to take, that
Yeah.
you have to take charge of the health of the Indians.
Indian, yes, one has to take the ownership. Because the Mohalla clinic also did not do very well, but they are there, of course. And Dr. Shah, again to you only, my last question. This is, to Dr. K.B. Sood, I'm sorry, Dr. K.B. Sood. This is also related to the beds per population. The global average is 3.2 bed per 1,000 population. I mean, we are still, far from it. India is still far from it, falling short of nearly 3.5 million beds. And although well below the average, the shortfall reduces to 2.4 million with the inclusion of private beds, highlighting the overarching presence of private healthcare services in India. So this one actually the topic, if we understand, we have been talking of the district hospitals to be converted to medical college, but what we want to project here is that it's not only the medical college, district hospital or referral hospital getting converted to medical college, but in the vicinity, some small hospitals around, if they can also be part of this project and merge as a cluster, we call it Medicity. So what would be the advantages, or what are your views on that if we propose some such model to the government?
I'll give you an example. You have PGI Chandigarh in Chandigarh. You go another 150 kilometers, you have AIMS, Bilaspur. Go another 150 kilometers, you have a medical college, ESI Medical College in Mandi. Then you have a district hospital, 300 beds in Kullu. Then you have a district hospital in Lahore, district hospital in Spiti. You don't have that many patients with the national norms to fill these beds. So you must have a system that you are little sick, you come to my health center. You become bigger, more sick, come to district hospital, more sick, come to AIMS, come to PGI. Then same number of beds will be able to take care of that population. Today what is happening is everybody is running to Chandigarh.
तो ये कह रहे हैं जहाँ पे कई बार पेशेंट है बेड नहीं है, जहाँ पे बेड्स है वहाँ पेशेंट्स नहीं है. So the disparity will remain across. There is no equal distribution. I think Mr. Rajiv wants to add something.
Because this was not only regarding the topic of discussion, not only regarding the policy and the hospital bed infrastructure. We've seen successful models of, I would say, hubs being created, like Medicity you're talking about. So there are two medical hubs which are already existing, mission hubs, what we call them, where Department of Science and Technology, Department of Biotechnology work with the CSR in Chandigarh and Annamalai University in Chennai. And these institutes are working on developing medical technologies along with the, for example, PGI in Chandigarh over there, the IIT at Ropod over there. So there is a cluster that has been created in the Chandigarh belt. There's also a cluster that's been created in the Chennai belt over there, where there are linkages between the industry, local industry over there, the academia over there, as well as the hospital chains over there, as well as the engineering institutions over there. So all the four components have been integrated. Now the question is making that into a more robust model, successful output model, and then replicating it all over the country. So going back to your basic topic over there, first question is, so many medical colleges required. We already concluded, not required, not in every district. There are 28 states in the country, 8 union territories, 36. Do we also need 36 clusters in the country? I don't think so. So
You already have more than 60 clusters.
that's for medical. I'm talking about the clusters. When we talk about Medicity, where it is linked to engineering college, linked to
Engineering,
industry.
biomedical engineering connected, there are more than 60 clusters. 60. You don't have staff. You don't have enough capital for them to work. I have made a research laboratory in most of these institutes. What is that research? That's a translational medicine research laboratory. That means you give me the basic model, then I will translate that to the human use.
No, in US,
Where is the basic feedback? Where is the basic?
Very true.
Where is the equipment?
no, in US there was a model, I think Mr. Rajiv Nath can answer. Eds and Meds, education and medicine.
Also there, and you've
So
got the
how
John
do you
Hopkins.
think this medical university industry linkage?
Yes, that's where I said like John Hopkins and what you just mentioned over there. So there are states over there in USA has got that, but even USA, which has got 52 states, like 52 countries, like India's got 30 plus countries in India also, does not have this in every state. It's not required. But yes, the country should start at least with something which is zonal. So at least 5 zonal really thriving clusters are required. Now some initiatives are taking place at an individual personality level. You've got IIT Kanpur linking, creating a medical college in its facility over there, reaching out to King Edwards over there, cross-linking to BHU over there, and trying to create this kind of an ecosystem along with the HPIE to make software in Lucknow, along to make a medical device park in Noida over there. So this becomes an interdependent system, for example in UP. So this is what we're talking about, but we don't need to go for it in every district. It's completely impossible. Think about it. Not really required. We will be getting overcapacity even in industry and then overcompetition in industry.
No,
But what is required is
not
at
correct,
least
sir. Not correct.
4 to 8.
Theoretically, your IIT Delhi is with AIIMS. Okay? Now, where you will make the medical device in the IIT Delhi or in the... That decision has taken 5 years. And where is the capital? Making a medical device is not easy because you have to go through the human use translational. So this has to be a policy, and in India you make one good enough. Okay, we are too many, make 10, not 60. You spread out your capital all over without
Yes.
doing anything.
I
I can give you the full list.
Very
I
right.
tell them, don't do this.
Mr.
Why
Rajiv.
make a research laboratory? It is much more expensive than a standard laboratory. Why
Well,
make it everywhere? They have made it compulsory, MCA made it compulsory. No, we want scientists, make laboratory. What kind of scientists we have?
I think Mr. Verma, you can say
Sir,
something, and I think after this we'll wind up because we have
Sir,
slightly overshot. Doesn't matter, but we will just wind up after this because
working
we don't want to take more
with
time.
so many international companies, what I learned in my 23 years of career is that, which is very interesting for me, that every country have people from the industry. Like respected Rajiv Nath sir told that, why can't we make beds here? Why we are buying from Striker? Why can't we do that thing? Because in the country, the biggest problem is that we are not having people from the industry who give input on medical devices, who give input that what we need to make and when we need to make. At the COVID time, everybody talk healthcare is the main reason. Now we'll go for healthcare. But we are not taking the advice or board members from the industry who know the subject. For education, we say you are professors. Sir, by default, we are also professors in our field. But these professor services are not being taken. People who are not from the industry, they give input. Oh, you can develop this thing.
How passionate Mr. Verma is about it, I think he's right. It is, it has been offered and the theme offered when we are talking of provision of safe and quality healthcare. It we have to involve all the stakeholders.
Every country, sir, every
We have a
country there is.
consultative approach. Absolutely right.
Every country,
Even-
there are people from the industry who are working to develop in that country because they want their country to grow. And very true.
All right, I think we have come to the end of the session, and thank you so very much to all the esteemed panelists. I think this is one of the very, I must say the the most happening session which we had at the end of the day. I could see still people are there, alert and awake. Dr. Rai is giving us a very beautiful smile. Anyway, thank you very much to all the panelists and all the audience. Of course, without the audience, this could not have been a success. So thank you very much for patiently listening to us. And I must like to thank the organizer once again, Mr. Afzal Kamal, the hero of this show. Of course, where is Mr. Manish Rastogi? I think these two people, they are so passionate about this event, and they've been working day and night for this event. And anytime you talk to them, they are always there to help you, to guide you. I must compliment them. And this is not, of course, the end of the conference. We have another day tomorrow. So this is the end of the day. Probably there is one more session. So I will not take much time. Thank you once again.
Thank you
for
so
the
very
opportunity.
much, sir.